All right, there we go. And then before you start, Dr. Medina, please let me introduce you to everybody. So again, welcome everybody. Dr. Hector Medina is presenting today. He is a wonderful cardiologist who focuses on cardiac MRI. He received his MD from Javeriana University in Bogota, Colombia. He went on to do his internal medicine residency at the Cleveland Clinic, cardiology fellowship at the Baylor Texas Heart Institute, and then specialized in cardiac imaging at Massachusetts General Hospital. Currently, he's the director of cardiac imaging at Baylor Scott and White in Round Rock, Texas. So without further ado, Dr. Medina, I give you the floor.
Thank you, Eva, and thanks so much for the invitation and all to all our colleagues and friends in the Chagas network. I'm here to talk to you guys in the next 30 or 40 minutes about cardiac MRI and Chagas cardiomyopathy, and I have no conflict of interest. And during the next, as I mentioned, 30 or 40 minutes, the idea is to take you through a kind of a time travel between the original description of Chagas disease to the latest cardiac imaging guidelines about patients with cardiac Chagas cardiomyopathy. And I think it's a fascinating trip. So we're gonna go ahead and get started. Uh, Before even we talk about anything in Chagas, I just want to underscore the importance of image quality, uh, and because it's a must, and it not always happens. CMR is expensive, is not available, and unless you do a certain amount of cases a day, your image quality is not going to be ideal. And the idea is to see neat flowers like the ones on the left, and to avoid the flowers that you got on the right. So that's just kind of a message, but it's extremely important that everyone is aware when they're either interpreting scans or they're considering that the diagnosis of Chagas, or when they're thinking about treating VT or treating this disease, to have the most pristine images. One of my attendings used to say that CMR is like real estate. It's all about location, location, location. And you can have a really nice house, or I can have a normal house, or you can have a really crappy house. But the ideally, of course, is to stay within the best location possible. And the same thing happens for CMR. So this is image quality. The one on the top, the one we were trying to focus, which you see here, is an apical 4 late gadolinium enhancement imaging. And you see nicely how that you have the right ventricle here, the left ventricle, for those that are not familiar, the right atrium, the left atrium, and the null myocardium, or the black myocardium, like the one you have here, is very different from this one here, that it's imaged 10 or 15 minutes after we inject gadolinium, and you see nicely this whole scar from a patient that has cardiac sarcoid. And you have so image quality. This is back when I would train at MGH. We didn't have the kind of technology that we have now. And you definitely see in this short axis, you see the left donut and the right donut. And then the left donut is the left ventricle, and the right donut it's the right ventricle. And you see some, delayed imaging here, some black, some white myocardium compared to the black myocardium. And then you have the image quality that is really crappy right here. That'll give you a percent of the case. And the idea is just like in real estate, is to have the best image quality, to have the best location possible. And I think that stands for any condition, including Chagas and non-Chagasi cardiomyopathy. So again, to reinforce this concept, this is a real estate case. He's a 42-year-old male referred for PVC, premature ventricular contraction ablation, with an EF of 45%. And the outside CMR official read says multiple areas of scar, the white portion of the myocardium at the base, mid, and apex, with subendocardial and mid-myocardial distribution. The EP, during the EP studies, when the catheters are in, however, showed no areas compatible with the cardiac MRI findings. And I was called to the cardiac MRI to interpret the study. And this is the study that I looked at, which is the real black arrow. I'm sorry, the red arrow, the bad location, the bad cardiac quality, the image quality. And certainly you cannot tell what's normal from abnormal. So what we ended up happening was that we repeated this case, and this was normal. So image quality is an absolutely priority for those of us that are either doing it, interpreting, or for you guys who are going to be using it. So we want to avoid this, and we want to stay in the left lane, basically image and pristine image quality. Now, this cardiac sarcoid, just as a bonus, is very similar to what you can see in Chagas. Chagas and sarcoid are kind of cousins diseases, and they can give very, very similar patterns. And when you're diagnosing someone with, or you're thinking about a Chagas disease, if everything is negative about Chagas, then the second most common differential in this patient would be sarcoid. The same thing that if you're having a sarcoid patient and that everything is negative and you confirm that there's no sarcoid in a patient, either by biopsy, then the differential diagnosis should be Chagas. But anyway, as far as image quality goes, try to stay on the left lane, and this is one of the take-home messages for today. Stay away from the right. And ideally, you should be, if you're in the clinical arena and obviously you're a cardiologist or you're working with your colleagues like Eva, your infectious disease doctor, you want to discuss the case and make sure that if there's any doubt about the image quality, the test needs to be repeated. So the original description, as you know, as we start our travel throughout time, the initial one was in 1909, and this was close by Colombia, where I was born and raised, and I went to medical school, as Eva mentioned. And this was by Carlos Chagas, and this is his original, the very original description in 1909. So we've been aware of this disease for more than a century. However, cardiac MRI came late in the game. This is a typical, um, circle of disease. You have the bug, usually the patient gets bitten, and all the trypomastocytes get, reproduced or circulated into the body. And then this whole vicious circle starts. And this is the chronic Chagas cardiomyopathy with a left ventricular aneurysm. So one of the other things that you're going to see us saying during the talk is that the left ventricular aneurysms, particularly the apical ones and the infralateral ones, are very, very common. But this vicious cycle has been known throughout the years. However, only in 1998, the first cardiac MRI description was made. And it was not made about a scar, but it was made about inflammation. And this is in 98, before the era of giving gadolinium to patients during cardiac MRI. And this was done, not surprisingly, in the University of Sao Paulo in Brazil. And these guys, this was the first attempt in 10 male patients with cardiomyopathy secondary to Chagas to try to obtain images that would describe how Chagas behave in the heart. And what you can see here is black blood imaging. We call it black blood. Remember the donuts that I was mentioning in the prior slide? This is the left ventricle, this is the right ventricle, left ventricle, right ventricle. And this is a healthy subject, and this is an inflamed subject. And the way you can tell the difference is because this is a sequence that is very sensitive to water. So you have inflammation or water in the cells, the image will come bright. And this is a T2 black blood image sequence in which you can see marked inflammation of this left ventricle, both in the anterolateral and the infralateral walls compared to a normal subject. So that was the very initial description that was ever done. And it was published. There was not even a journal of cardiac MRI. It was published in echocardiography, which is obviously not in the same. It's an imaging journal, but it's not the journal you would publish, because there was no cardiac MRI almost developed at that time. And then what happened with this particular patient is that you can see actually the whole inflammation and edema in the myocytes when the patient eventually died, and the autopsy on the heart specimen showed these under the microscope. So just a year later, just 1 year later, the first description of late gadolinium was done, but it was not done in humans, it was done in dogs. And the principles behind gadolinium are that you have normal myocardium. Here's the guy. These gray spots are gadolinium. And when you have normal myocardium and you have integrity of your cell membranes, the gadolinium washes quite fast. However, if you have acute infarction or scar, the gadolinium tends to stay. And the gadolinium helps or aids the magnetization of the heart faster. So when you put the patient under the magnet, the magnetization, it's faster. And it's the mark here as the white arrow, as the white spot. This has a typical mid-myocardial distribution compared to the null or black myocardium. Again, left ventricle, left donut, right ventricle, right donut. Well, this doesn't look like a donut. It's more like a triangular donut, but I'm just telling you that the shapes for you guys to if you're not familiar with cardiac imaging. And this is a scar in the anterolateral and the inferolateral wall with mid-myocardial distribution. And that's was found by initially by the people in Northwestern. And if you see the cardiac MRI resembles very similarly, almost identically, the pathological specimen. This is a dog. And again, this was taken during cardiac MRI, and this was taken after the dog was sacrificed. And it was first published, as I mentioned to you, at the end of the century in 1999 by Raymond Kim and Robert Judd. And this completely changed the history of cardiovascular medicine and cardiovascular imaging, because now we can have something that was very, very similar to the really true specimen. This was done on dogs. What they did is they ligated the left anterior descending artery, and they imaged at 3 days, 8 weeks, and they finally sacrificed all the dogs. And they realized that they found a very, very nice imaging technique. Every time you have scar, chronic inflammation, or an infarct of any type, mainly obviously ischemic, but it can have scar from many other conditions, and we'll look at those in a minute. Then you will be looking at images that are white on late gadolinium enhancement. And this is him, Raymond Kim, changed the history of medicine. He went to Duke, became professor of medicine at the age of 39 or 40. So this discovery really changed his career, and it changed the way it imaged our hearts. And every time you put a patient in a cardiac MRI, you have almost the obligation of, you never get off the mountain without a diagnosis. So this is one of my attendings in Boston, and he's a veteran of many battles. He's an amazing attending and a brilliant man. And really, when you're doing cardiac MRI, after all those things that others have discovered, you really have make your obligation of trying to get a diagnosis, or a very good differential diagnosis at the end of the study. So let's go on review cases, because we all like cases. This is a 35-year-old man complaining of fever and syncope in Boston at the end of a marathon. He had normal EKG. His enzymes were markedly elevated, with a troponin of 35 and MB of 347, and he had a coronary CTA and a TTE that were normal. However, he sustained VTAC and required to be admitted to the ICU and start the whole ACL protocol. And it was not very clear where was he having all his enzyme leak with this VT if his coronaries were normal. And this is his apical 4. This exactly looks like, the type of image that you get on an echocardiogram. And you have the CMR on the left, the cardiac MRI on the right. And one of the advantages of cardiac MRI is that here you can see very clearly the delineation of the lateral wall. If you go to the right, on the echo, this basal anterolateral wall is not as easily ascertained as it is on the left. So those small details are very, very smooth and very refined spatial resolutions are one of the advantages of cardiac MRI, in addition to tissue characterization that I just showed you with gadolinium. So one, it has a very good spatial resolution in the sinus, and also it provides improved image characterization to compare to a cardiogram. Going back to our patient, he has normal sinus, normal EF, but on the cardiac MR, remember that case that I showed you at the beginning when we were talking about location, image quality, image quality, image quality. This patient has subepicardial late gadolinium enhancement on the anterolateral wall and inferolateral wall of the left donut of the left ventricle that are classic for myocarditis. And the same author, Raymond Kim, also described these patterns of late gadolinium enhancement. Here we have the null myocardium of the left donut in black, and anything that is white, it's gadolinium that is being deposited in the myocardium because the membranes have been disrupted or there's chronic scarring. And as you can see, these 4 conditions, sarcoid, myocarditis, Anderson-Farris, and Chagas, have either mid-wall or subepicardial distribution. We'll see that there are other findings that we have noticed lately that can resemble the Chagas disease, can also have transmural infarct, but in general, these 4 conditions resemble the same distribution in late gadolinium enhancement. So we go back to the short axis and to the long axis. This is an apical 4. These are the short axis, left ventricle, left ventricle, left ventricle. And when you cut when we do the planimetry, not the planimetry, we will do the planes like this, we get this apical 4, right ventricle, left ventricle, left atrium, right atrium, and we see these white spots, which implies that there is definitely some scarring in this patient that was diagnosed with myocarditis. And why is this important? It's very important because the utility of cardiac MR is not only for detecting what type of cardiomyopathy they have, but especially for those that are presenting with malignant and ventricular arrhythmias. This is a paper that is 13 years old already, but it's a classic. It's one of those White papers. And what White and colleagues did is that they took 82 patients with resuscitated sudden cardiac death or monomorphic VT, and they classified them as the diagnosis before and after the cardiac MRI. And in 74 patients, using cardiac MRI changed the diagnostic yield, I'm sorry, of cardiac MRI was 74, and 50% reassigned a new or altered diagnosing using cardiac MRI. The best way to describe this is with these pie charts. So if you look at these 81 patients before the cardiac MRI, almost 49% were considered normal, which is the dark blue here. That means that a lot of the times when patients present with sudden cardiac death, we don't know what's happening really. However, when we do the cardiac MRI, that normality, quote unquote, decreases by almost half, and a lot of new diagnoses start to come into the game, such as coronary artery disease plus without left ventricular dysfunction. That's what CAD and LVD stand for. And if you look at the biggest one that grows here, on the right-handed side pie chart, it's inflammatory diseases and also HOCM. So without cardiac MRI, assessing for coronary disease without LV dysfunction, HOCM, hypertrophic cardiomyopathy, and inflammatory is extremely difficult. And that's one of the additional benefits of cardiac MRI, and is that in this type of patients, the real reason for VT or sudden or aborted sudden cardiac death can really be ascertained. Another take-home message I put my Eva was very insisting of giving you take-home messages. So every time you see a home here, that's a take-home message. When you do cardiac MRI in patients such as this, you're absolutely way more certain that you're getting you're nailing the diagnosis and helping prevent another event. And then in 2000, again, Kim published this in the New England Journal of Medicine. This is not now in dogs, but in humans. And this was the patient was in the title was the use of contrast enhanced magnetic cardiac MRI to identify reversible myocardial dysfunction. This is how a typical transmural LED infarct would look like. You see all the gadolinium staying there, and the null black normal myocardium is black. And in this one, this is a circumflex, right? This is an infralateral and anterolateral wall. And as you can see, the size of this infarct is not as big as the size of this one here. So when you revascularize this circumflex artery, or when we revascularize this right coronary artery, there's a pretty good chance that this myocardium will come back and this viable myocardium will work again and the EF will improve. That same thing doesn't apply to this transmural infarct. You see right here, this is none. Regardless if your LAD is opened or if you put a very good lima to an LAD, this territory is dead. So that's one of the additional of this seminal paper published 25 years ago. So again, we're going back to our typical distribution of our ischemic cardiomyopathies on the left of the non-ischemic. And the paper that I just showed you that was from James White was corroborated by the people both at MGH and the Brigham, and they all got together and studied kind of the same thing, survivors and using late gadolinium to reassess diagnosis. And essentially the same findings were done a few years later. The diagnostic yield in these cases was against 76%, which was much better compared to the traditional cath and echocardiogram. The definite diagnosis of this patient was myocarditis, not Chagasic myocarditis, just regular, good, and the bread and butter viral. But again, obviously help the treating clinician optimize his care. So we've been going through almost half of our journey, and now after 1999, when gadolinium was used initially in dogs and then in humans, then we can start talking with other people, in particular in Brazil, start using in different cardiomyopathies other than ischemic. And that's when another case comes into play. 59-year-old male in Colombia, history of stroke, and he had transthoracic echocardiogram with renal wall motion abnormalities, but the image quality was not great. He had normal coronaries, and he was referred for cardiac MRI. So if you look at a cardiac MRI in a patient like this, and you look at these apical aneurysms and inferolateral aneurysms, this is absolutely no doubt Chagas disease until proven otherwise, especially if they have thin coronaries. And if you see how the septal wall contracts, how this anteroseptal wall contracts, how this anterior wall contracts, how this is thinned apical left ventricle and thin inferolateral wall, you can clearly immediately tell, okay, there's something that is funny. One, this is not contracting, right? This is not thickening. And two, is very thin. So if you have someone coming from Latin America with a stroke or with any cardiac event with this type of sinus, you should immediately suspect they have Chagas disease. Now, this is exactly how it looks. And this is how what the LG shows transmural infarct, oops, sorry, in the apex, right here, right here, right here. This is an apical 2, an apical 3, and an apical 4, just different ways of slicing the heart. And if you see here, right inside this aneurysm, this is what they gave this patient the stroke. This patient has an LV clot. And it wasn't ascertained by the echocardiogram. It was ascertained by the cardiac MR. So we have a very young 58-year-old guy coming for the first time as initial presentation with a stroke that was never diagnosed with Chagas, coming with a typical cardiac MRI findings consistent again with apical thinning and transmural MI and transmural late limb enhancement, inferolateral thinning and aneurysm, and with this distinct stroke, which was what originated having an embolic phenomenon. It's very sad, but this is a very common presentation in our countries, in Colombia and in other countries. And this can only be ascertained completely and for sure by cardiac MRI, another huge, huge component. So I just mentioned to you guys that the mid wall and the subepicardial wall are Chagas based. This is like the classical description, and that the transmural infarct is usually ischemic. Well, we published this a few years ago with Leslie Cooper. He's a good expert in myocarditis. And when we start looking at all the images that have been published up into that moment, what we found out is that almost 50%, 44% of the transmural infarcts by CMR were transmural. So this particular thing that you're going to find, this particular diagram that you're going to find in every single textbook, it's in every cardiac MRI textbook, is not certainly true. If you look into all the papers that have been published up until 2018, 44% of the patients that have Chagas scars happen to have transmural. So another take-home message, very important. Not all Chagas disease have subepicardial and mid-myocardial scars. Up to 44% can have transmural scars as well. So again, we see how a patient got diagnosed, but the first person who really described it was Carlos Rochid, who's a good, an amazing cardiologist, an amazing imager, good friend from Brazil. He did this when he was already back in Sao Paulo. He trained at Hopkins for cardiac MR. And what he did is he took a lot of patients with Chagas cardiomyopathy, and he analyzed those that had non-defined disease, Chagas cardiomyopathy, and those that came with VT. And those that were the sickest, that were only 10 of all the whole 51, were a little older, had worse EF, as you can tell, compared to the other ones, had bigger ventricles, and had a lower or a worse functional class. So he took all the Chagasic patients, indeterminate state, definitely those with Chagas cardiomyopathy, and those that are coming with the worst presentation with VT and were the sickest. And these are the original pictures in the indeterminate Chagas cardiomyopathy and VT. And you see how the healthiest patients had almost normal scans, how the Chagas cardiomyopathy had some degree of late gadolinium scans, and how the sickest of all had the most extensive amount of scar. There are some other papers that I'm going to show you, but again, and it's also an important take-home message, this is the paper that I showed you initially during the real estate location, image quality, a patient with sarcoid. And if you look at the original description, sarcoid and Chagas disease are cousins. They're very, very similar. And every time you consider one differential diagnosis, you consider the other one. And this is just to show you how these transmural scars, including compromise of the papillary muscle with subepicardial distribution and subendocardial, just like here, it could be either or disease. Very important thing for you guys to remember. So moving along, we continue to the description of the original paper. This is MF means myocardial fibrosis. And then we are just looking at all the patients that had some degree of myocardial fibrosis and the percentage of them. And if you look at those that are indeterminate, those with Chagas cardiomyopathy, all of the patients, 100% of the patients with that were coming with the sickness in the original description of 2005 from Brochit did have LG. And then other papers published by Brochit and others became very popular during the next few years. They were published in the Journal of Cardiovascular MRI and the International Journal of Cardiology because it was a new description, right? It was a new technique of imaging the heart that was being explored into all conditions, and Chagas happened to be one of the most interesting just because the amount of scar that these patients do have. Now, if you try to understand what's going on in these patients, there's two things that happen: vasculitis and acute myocarditis. And this is just a vicious cycle. Vasculitis, myocarditis, and depending on obviously Eva and Bob are experts in terms of what brand of the infectious of the what type of traumatic you get. They can provide 7 or 8 different types, and some sounds like they're more prone to promote this chronic inflammation. And this is extracted from a patient in which both vasculitis and acute myocarditis was happening on and off during the course of the disease. There's one question that has been asked that it doesn't have a definite answer, is why the apical and the infralateral walls tend to have the highest distribution of disease. And one theory, it's actually Carlos's Rashid again theory. He published this elegant paper in Artificial Organs in 2007. And when you see this, which is the infralateral wall, and this, which is the apical wall, these are the very end of the circumflex artery and of the LAD. So when you have inflammation and when you have coronary steal of all the vessels the patient is in an acute or chronic inflammatory state, and all the vessels are vasodilated, that territories, the myocardial territories that suffer the most are the ones that are distal to these arteries, because all these territories that are proximal to the distal LAD, circ and LAD territories are stealing all the blood. And that's one of the theories that we can explain why these apical and infralateral wall aneurysms are so typical. It's a paper worth to read, and it's a better explanation that I found of the distribution of the Chagas aneurysms. Now, there's 2 types of morphologies. This is a courtesy of a friend of mine in Colombia, Julian Forero. And these are 2 patients. This one is morphology type A. This volume is normal. It has a 62 mL per meter squared with a normal EF. And it does have, as you can see, some scarring, again, the typical apical scarring and infralateral scarring, but the EF is preserved. It's not a very, very diseased heart. However, this is morphology B. Here, this is a ventricle which is more than twice as much as the one I just showed you, and the EF is much lower. So depending on the patient, maybe on how much interaction there is with the inflammatory or the pro-inflammatory state of its particular trypanocyte type, then it will depend on how much acute inflammation both patients are Colombian, both patients have the same disease, but this one is significantly sicker. As you can see, the prior one has a ventricle that is smaller, 62, and with a ventricular function that is higher. And patient number 2 is a patient with a much bigger ventricle, and which have of them as much of ventricular ejection fraction. So we don't know why the differences between the 2 of them, but it could be the same pattern of disease. Maybe it's that the type B was caught earlier, but again, they present with different sizes and different ventricular functions, and they both need to be recognized and treated. If both of these patients have clean coronaries, the diagnosis of Chagas disease is almost made. So as we're coming to close to an end, what we know now is that LG is not only a very good way to diagnose or to suspect Chagas cardiomyopathy, but also to predict outcomes. And that's extremely important because the more fibrosis you have, the more likely you may need an ICD, even if there is normal ejection fraction. So that's important. The first paper that really looked into this was actually Rashid, the one I mentioned, and also Gustavo Volpe and others, also from Brazil. In this study, Joao Lima was also included. Looked at the pattern of enhancement in survivors in patients with Chagas cardiomyopathy. 26% or 26 of them had no scar, and 95% of them had scar. And as you can see clearly in this Kaplan-Meier curve, those guys that had no scar were more prone to survive compared to those who did. So this again was the first publication in almost 100 patients, and the largest one was again by Rashid from Sao Paulo. He published this in 2018, and what he noticed is that the myocardial fibrosis extent was very predictive of a combined 8-point endpoint and also of just death. This is just death, and this is the combined input of death, heart failure, hospitalization, and shock in those patients that had ICD, and both were significant. So the higher the number or the higher grams of myocardial mass that you have scarred in patients with Chagas cardiomyopathy, the prognosis will be, will be worse compared to those with less amount of scar. And the last thing, after all these long amount of discoveries, the first one in 98 with inflammation only, then by Ray Kim assessing scar, and then Rashid and others assessing both how cardiac Chagasic patients look under the magnet and how much LG can serve as a predictor. They come up with the imaging guidelines. It's a paper that's worth to read. A bunch of people put in a lot of effort into it, and it's called Multimodality Imaging Evaluation of Chagas Disease, an expert consensus of the Brazilian Imaging Department and the European Association of Cardiovascular Imaging. Again, worth to read for those that are interested. And the amount of effort that was put into this was enormous because it basically represents a century of development and discoveries. So just to go back to our take-home messages, in terms of image quality, I cannot reinforce enough. You have to stay on the left lane, try to avoid the right lane. You can imagine the amount of scans that look like this in certain hospitals in the US and in Latin America. We need to put attention of that. That's our responsibility as imagers. Very, very important. Remember these pre and post cardiac MRI diagnosis in those that are survivors of the sudden cardiac death. Putting the patients into the magnet can definitely decrease significantly the quote unquote normals and help you find other diagnoses that are essentially in the management and prevention of recurrence of sudden cardiac death or ventricular tachycardia. Remember the typical distribution of Chagas disease, it's historically described as mid-wall and epicardial, along with sarcoid, myocardial, and Anderson-Fowler. You now know that the null myocardium is black and the white myocardium is scarred, and that this distribution may follow Chagas disease. However, in this transmural infarcts, just like here in the apical and the inferior lateral walls, are also very, very common. Remember the location, and that up to 44% of the scars in cardiac MRI in Chagas disease are transmural, not subepicardial or mid-wall. And finally, that after acknowledging what does the scar looks like, where are they typically located, apical and infralateral, how they may look like mid-myocardial, subepicardial, transmural, the presence and the quantification of scar definitely pertains prognosis. The more scar you have in those hearts, the worse the patient will do in terms of a combined endpoint of heart failure admission, death, hospitalization, and ICD shocks, and of just death. Very, very important and a very strong predictor for outcomes. And what are the challenges? Understanding pathophysiology's mechanism by segments, the patient immunologic pathways are things that we're not very clear is the cycle of inflammation versus fibrosis. Remember that slide of vasculitis and scar that we talked about. And just like, Bob and Eva and everyone else probably in this network, building networks with US and Europe, it's granted rather due to the fact it's a global burden now, and assembling large cohort, hopefully with thousands of patients to determine the true value of cardiac MRI. And that's basically it.
Thank you so much, Dr. Medina. That was a fantastic presentation. We have a couple of questions in the chat, and I'd like to also open it up to people to unmute themselves with questions if they like. But let me start with the chat. So first question, and just shout out to our tropical medicine and global track fellow, Jishna Shrithra, who is asking the question. So her first question is, how long does the gadolinium stay deposited in the myocardium? And does it cause any long-term issues?
So very good question. So the myocardium stays there for probably another 24 hours after we image, but we tend to the best time at both logistically and from an imaging perspective, the best time to image it is 10 minutes later. So those I don't know if you're still seeing the image, my screen, but these images that we take, we usually take them 10 or 15 minutes after, but the myocardium stays there a little longer, probably, a day or so. But if you scan this patient, I don't know, a week after the initial scan, you will see no gadolinium. It will eventually will wean off. And if there's any risks, no, there aren't any risks. There were some risks that were certain gadolinium that we're not using any longer in terms of those patients that would have abnormal renal function, particularly those that have end-stage renal disease or those with acute renal failure. They will tend to have, they can have something that is called NSF, which is nephrogenic systemic sclerosis, which is a horrible disease. But now that was with an earlier type of agents. With our current agents, particularly with Gata, which is what most people are using, the risk of NSF is virtually zero, and we tend either not to scan patients with acute renal failure, or if they're in dialysis, we'll do the study, and they will go from the magnet to the nephrology unit to get dialyzed and get the gadolinium taken out.
Thank you, Dr.
Thank
Medina.
you.
I have a follow-up question to that. Does the patient need to have a certain heart rate, like around 60s, like the patient not, does the patient, if the patient is tachycardic, do you give any beta blockers in these cases?
No, that's a very good question, because I think what you're alluding to, the person who asked the question, is that for cardiac CTA, we like the heart rate to be low. We like the heart rate on the 60s, and in certain centers, they don't use beta blockers, but some of us still do. And the lower the heart rate, the better. For cardiac MRI is not as much needed. When they have a lot of PVCs, we need to give some beta blockers to decrease the burden. But you can have excellent images with the heart rates of 60, 70, 80, or 90. It doesn't matter as much as it would for cardiac CT. Very nice. Very, good question.
Thank you.
Also, Rachel Marcus is in the audience. Hi, Rachel. She's been fielding some of a question about Takotsubo in the chat, so I just wanted to also acknowledge her there. I knew we were going to get to some questions about cost, and so the next question's related to cost. Karim in the audience asks, if uninsured, are there national resources or nonprofits that can help with costs of care, like for CMRI, for patients who need that?
Well, if they have no insurance, I think that's a problem, unfortunately. I mean, they can still use county hospitals, and I know some county hospitals are doing very good cardiac MR, but if they don't have any insurance, I think that would be the only pathway. When we're working with on the grant, it turns out that at least in Houston, getting a cardiac MRI was cheaper than getting an echo. So these costs are kind of random. If you ask me, I think a cardiac MRI should be more expensive than an echocardiogram because it takes longer. It uses the magnet for a long time. it's more complex, and I do echo as well. I think echo it's the gold standard for imaging, of any imaging for cardiology. But I think there are ways to get around it. But I think it's difficult if you don't have insurance. I think that the county way would be the way to go. But surprisingly so, as you know, Eva, and as Bob knows and Rachel knows, at least in our side, it was in my prior side, it was easier to get a cardiac. It was cheaper to get a cardiac MRI than to get an echocardiogram.
And Dr. Medina, on kind of building on that question, can you speak a little bit to image quality? Because as you know, one of the issues that we've seen, you know, in our situation, practicing in a low resource health system in the United States, one of the challenges we had with cardiac MRI is relatively poor image quality. What are your thoughts on improving that?
I think I trained at MGH, and I've worked in New York, in a university hospital, and in Round Rock in Austin. We're not doing that cardiac MRI much at that time. And now I worked in Houston with you, Eva. And I think that honestly, what imagers need to do is they need to be extremely honest with themselves and see to those patients that are going to the county hospitals if they're getting good images. Because if they're not, and it's not that hard. I mean, now with artificial intelligence, it's much easier to do the scan and much faster than it was 10 years or 15 years ago when I trained. When I trained, I remember when I was in Boston getting a cardiac MRI was probably 90 minutes. It was painful. Now you can get a full study with 30 minutes. And in the last cardiac MRI meeting that we have a couple of weeks ago, they're working on certain softwares that it can be done faster and easier without having a lot of expertise by the techs. So I think AI might help if you have a magnet, which is good. And the magnets are not different. They're the same magnet that can do a brain, can do a knee, can do a shoulder. So they're not that different. There's usually only 3 brands, GE, Siemens, and Philips are the 3 brands that are utilized. And what the field is going is to make sure that cardiac MRI is not only for certain hospitals, and you have to be at the medical center in Houston, or you have to be at Hopkins, or you have to be at Georgetown, that it can be more available to the bread and butter hospitals, so everyone can have decent scans. As the time being now, I think you still need a fair amount of expertise by the techs and by the physicians who are doing the studies. But I think down the line, and I think probably going to be 2 or 3 years, and there are numerous companies particularly too interested in this, is you put the patients in a magnet, you get certain localizers, and AI will start taking over into doing the study in the best way possible. And I think this, or having CMR restricted to only certain hospitals, I think is going to be, hopefully something from the past in the next couple of years by the new software that's being developed.
And other questions from the audience? Again, I welcome you guys to unmute yourselves. I thought I saw a question that I interrupted earlier. Rachel, I see you unmuted. Go ahead.
Yeah, so Hector, I just wanted to say that was such an incredible talk. I loved the overview and really fascinating. So thank you so much for that. I've talked with Carlos Rashid about a little bit about this question, and I wanted to get your input on it. So some of the papers that look at series of folks with Chagas cardiomyopathy and MRIs do have a certain proportion that don't have any scar. But we think about Chagas disease as being a scarifying cardiomyopathy fundamentally. So one question I asked him, and will now ask you, is whether or not you think that some of the folks that are actually in these studies have Chagas disease, but actually have a cardiomyopathy of another etiology that isn't scarifying. And if somebody didn't have scar, let's say you're doing an MRI on them and you don't see scar, would that decrease the likelihood for you that they had Chagas cardiomyopathy?
So that's a good question. So if some patients can have, let's say they have a low EF, and and they don't have the typical aneurysms that we looked at, that we showed in the apical and inferior lateral walls, and they have zero scar, then they can have that cardiomyopathy, have Chagas disease, right? They kind of have positive serology, but they can have any other type of cardiomyopathy. They can have non-ischemic, they can have iron-induced, they can have an old myocarditis that healed. So I think it still helps. I think it still makes a point. And also they can still have Chagas disease uh, and have, if they have coronary disease, which is just the most common type of cardiomyopathy, they can have a hibernating myocardium. So I think imaging, despite the fact they have absence of scar, would at least take out that hemochromatosis. There's a relatively common. We'll take out the non-ischemic. And in a way, you can ascertain if they do have risk of death. Because if you have cardiomyopathy, but let's say your EF is 38%, and you have no scar and you have a narrow QRS, that patient most likely than not is not gonna need an ICD. Whereas if you have a patient with Chagas disease, or let's say the Chagas disease that has an EF like the one I showed you, morphology A, that has fair amount of scar with a normal EF, according to Rashid's papers, that patient, when it's above 11 grams, will have a higher likelihood of having an event. So you may need to consider and go case by case. Okay, this patient doesn't fulfill criteria for ICD according to current guidelines, acknowledging the current guidelines have been not studied in Chagas patients. However, despite the EF is normal or not more or not less than 35%, if they have a significant amount of scar, I would think hard about maybe not putting an ICD on him because of the scar burden is such a strong predictor of outcomes. And I don't know, Rachel, your question had two parts. I don't know if I answered the second part.
No, that
accurately.
was fantastic. Thank you.
Yep.
I-
One more thing is, and I think the question in terms of the image quality, I think we're close to solving that. And there's two Siemens, one Siemens platform and one that is called Hard Vista. They showed again in Washington DC a couple of weeks ago these platforms in which they can perform a full study in 15 minutes, 16 minutes without an experienced technologist in the room. So what you need is a basic technologist, have the patient, locate where the heart is, put the localizers, and, hopefully that will help us overcome this difficulty that high quality scans are only done in certain centers. And I think that's a very important, not only for US, but also in Latin America, where we have some scans, but only a few centers. In Colombia, I would say 4 places you get, or not 4 places, but maybe a little bit more, but they're not more than a handful in countries like Colombia. Brazil, I think cardiac MRI is more accessible, but Bolivia, this, you and Bob know this, I think there are very few places that do need cardiac MRI and are not being done because of the lack of the resource or of the, sometimes it's, I'm not saying that getting $1.5 million is easy, but if I'm the government, I can buy the cardiac MRI, but training the tech, it's extremely difficult as well, and entails a lot of energy and health investment and resource investment. So hopefully that's going to come out. We'll see how the real world application of these softwares is going to work in the future, but I trust, especially, and I think this is very, very valid for stroke, because if you have Chagas disease and you scan the patients in time 0, and then you ask him to come back in 2, 3 or 4 months, and you get an echo, and we don't have echo contrast in a lot of the places in Latin America, and the patient strokes by year 5 because he ended up having an apical aneurysm and an apical clot, and no one wonders, and the patient is 40 years old, is a disaster. And that stroke could have been avoided if the patient could have had an MRI and the optimal method for ascertaining those is used. In general, in bread and butter cardiology, and Rachel knows this, the sensitivity of contrast echocardiography for a clot is 60 to 65%. Is not that good. If you take away the echo contrast, which is what happens in Colombia and in other Latin American countries, that sensitivity goes down to 30%. So in those patients that have disease, the sensitivity for echo without echo contrast, which is the technique that we use for assessing Chagas patients, it's absolutely horrible. It's better to the toss of a coin than the sensitivity of echocardiogram, non-contrast echocardiogram for LV clot.
Do you mind if I
so
tag team on that for just 1 sec? Is that okay?
Sure.
So one sort of case that I've now added to my talks is one of a patient where you hit the nail on the head, right? We did an echo, the apex was not well seen, the contrast swirled, we couldn't see the apex again in somebody with a bad heart. And it turns out that they'd actually had a CT of their abdomen and pelvis that showed not only their apical aneurysm, but their apical thrombus. So it's not, I mean, I love MRI. I think, and love to get MRIs in everybody with Chagas cardiomyopathy, but we also have some other tools in our toolkit. So, and since everybody going into the hospital in the United States gets some sort of a CT that includes, if it's an abdomen pelvis, you see the apex of the heart. If it's a chest CT, you see the heart. And you can always phone your friend, the radiologist or the cardiologist who's reading those studies to ask them if they can help you with that, because that actually is another way of answering the question if your echo is suboptimal.
Right. So cardiac CT is available everywhere. It's much easier to get a cardiac CT than to get a cardiac MRI. And if you're doing, if it's either by incidental finding, as you just mentioned the case, and we had a case just like that. I have it in here. I don't think we have time to show it, but it was initially called as LV diverticulum, but it was truly an apical LV clot that had a clot, an LV aneurysm, an apical ventricular aneurysm that had a clot in a patient initially presenting with a stroke. If that patient would not had a CT scan done, the echo would not have picked it. So yes, CT is always in your armamentary, and it's a good way of it has to be contrast for sure. But it needs, and sometimes you're lucky enough to catch them, and if they're on the left side, if the contrast is usually on the left side, then you can do that assessment.
Wonderful. Other questions from the audience? Norm, I think I saw you unmute at one point. Did you have a question?
Yes, real quick, Hector, excellent talk. I jumped on and off here, had some calls, but for those with indeterminate phase, they got their first cardiac MRI, no evidence of Chagas cardiomyopathy. Are you guys, what's the timeline for surveillance? Have you guys been utilizing follow-up cardiac MRIs to monitor for early disease? If you could explain more about that, that'd be great.
So that's a $1 million question, and is once you have an indeterminate form and you don't have a lot of scar and the aneurysms are absent, what will be the next time that you need to do it? And I don't have any data on this, any solid data, but I think that with echocardiography, you can follow them maybe in a year or in a 2-year periods. For cardiac MR, I would think that the length of our window it's larger. Probably if it's a solid normal cardiac MRI, the need to repeat it, probably it's not worth it in the first 36 months or even 4 years. I don't know what you guys think, Eva and Rachel think about that, but I think if you have a solid, if nothing changes clinically, if the patient remains functional class 1, if there's no arrhythmias, if there's no sudden cardiac death or not like a funny monitor with VT, I don't think there's a need for rescanning him earlier than that. I don't think, what do you think, Rachel and Eva?
Well, it's an interesting question. I think, as you pointed out, it's kind of an evidence-free zone, but there were the recommendations from the American Society of Echo and then a variety also of Latin American echo and other modality imaging that came out in the Journal of the American Society of Echo a little while back, where the idea is that everyone get an echo and an EKG at time point 1. If in fact they have an abnormal echo or EKG or both, that cardiac MRI is a very appropriate thing to do then. And then that the EKG should basically be done yearly, with an echo to be done either sort of at, every 3 to 5 years, or if there's a new symptom, as you alluded to, or a change in the EKG that would suggest that there's now new structural heart disease. So, but, I think it's a fantastic question, and one that it would be great if we could get some evidence for it to support.
Thanks, guys.
Yeah, I would just add with us, on the clinical side, it's challenging even to get an annual echo, much less. And, we're working on initial CMRIs. With us, we're working in a sliding scale system. So a lot of it depends on the patient's financial situation, and then whether or not their insurance will cover it, of course. Well, fantastic, guys. We are, pretty much at the end of the hour when we will be cut off. And so if there aren't any other pressing questions for Dr. Medina, I'm going to go ahead and say goodbye to everybody. I did want to mention that our next talk is going to be on May the 2nd. Dr. Medina actually showed the multimodality Brazilian guidelines with Carmenia Nunez as the first author, and she will be our speaker on May the 2nd. So please join us for that talk. And thank you so much, Dr. Medina. That was fantastic. We really appreciate you being here with us.
No, thank you guys. Thank you. A pleasure. Nice to see you again, Eva, and to hear Rachel and see all of you guys. And thank you so much. Exciting times, hopefully, and hopefully in a couple of years we're gonna have more cardiac MRIs being done easier than what's currently happening in both in the US and in Latin America.